and welcome to Live Healthy West Virginia, the podcast brought to you by WVU Medicine, aiming to help everyone live a better, healthier life in West Virginia and beyond. I'm your host, Mary Ravazio Menard. Do you have problems falling asleep, staying asleep, getting enough sleep? If so, it may not surprise you that West Virginians and those living in Appalachia are among the worst sleepers in the country, right? No big surprise. According to the CDC, nearly 43% of adults in West Virginia don't get enough sleep. And poor sleep has many health consequences, affecting everything from brain and heart health to diabetes. So today, we want to help fix your sleep problems by talking with Dr. Robert Stansbury, director of the WVU Medicine Sleep Evaluation Center. Welcome, Dr. Stansbury, to Live Healthy West Virginia.
Thank you very much for having me.
Well, I think this is a popular topic. Yeah. I think we're going to learn a lot today.
Yeah.
So let's start with just something very basic. How much sleep should we all be getting each night?
When you look at CDC and the American Academy of Sleep Medicine, most adults should get in the 7 to 9 hour range. Now, a lot of that is genetically determined. So, what's the right amount of sleep for me might not be the right amount of sleep for you.
Okay.
What I always tell patients is you can tell if you've had an adequate amount of sleep if you can wake up without an alarm. So you don't have that sleep inertia that your body's telling you, hey, you still need to get a little more sleep.
Okay, so that's good way to measure it. Yeah. Now, as we mentioned earlier, poor sleep has to be taken seriously. Right. And it has health consequences if you're not getting good sleep. So what are the health consequences of not sleeping well?
When you just look at general mortality, it's actually kind of a U-shaped curve. So, people who get inadequate sleep, typically 6 hours or less, maybe 5.5, you actually just see higher all-cause mortality. And then when you get to the other side of that curve, maybe 10 to 11 hours, people are sleeping, you also start seeing an increase in mortality, which is kind of interesting. Most of that is probably driven by chronic health conditions. So, if you have an advanced heart failure, malignancy, COPD, you're in a complete catabolic state. Your body tends to require more sleep. So it's probably a reflection of those chronic conditions, why you start seeing that increased mortality. But then when you look at, cardiovascular risk, stroke risk, you really see the same sort of pattern where lower sleep might be a little bit related to stress. You start seeing increases in those cardiovascular outcomes.
So it sounds like, getting good sleep and the right amount of sleep is a good health tip, to stave off a lot of things.
And, we always talk about diet, exercise, and sleep as the 3 pillars of health. But for the longest time, sleep was kind of ignored.
Yeah.
I think with the wearables people have now, people are getting more in tune to what their sleep looks like. So I do think it's getting on everyone's radar now. And like I said, it's one of the most important pillars of health. And there's a lot you can do to try and improve your sleep.
Yeah.
When we think about sleep, we talk about quantity, which is very important. And a big mistake people make there is you'll say, hey, I was in bed 8 hours last night, but that doesn't mean you got 8 hours of sleep. Most people, good sleepers get 85 to 90% sleep efficiency. So people tend to wake up during the night and not even remember it. Another phenomenon we see, people are pretty good at waking up in the morning because they have something to do.
Yeah.
But, it's very easy for people to say, oh, I want to see what happens on that next episode on this Netflix show. And
I've done that.
You see that creep.
Yes.
So you spend an inadequate time in bed. Then you think about the quality of sleep you get. So, we'll talk about some of the sleep disruptors people can have, sleep disorders that can influence your quality of sleep. But things like drinking alcohol before bed, caffeine, having a cup of coffee, after dinner, all those things can kind of pile up and, impact the quality of
Cause
sleep
problems.
you get at night. So.
Can you talk a little bit about good sleep habits? Because isn't a good sleep routine very influential on how you sleep?
Very important. And, really maintaining that normal sleep schedule is essential. And there's not only is quantity important, but maintaining that regular sleep schedule. Actually, there's been some research that might impact mortality as well.
Really?
Yes.
So we shouldn't sleep in on the weekends, huh?
Right. So, and I enjoy doing that as much as the next person, but, really, and it's important because it entrains your circadian rhythm.
Yeah. Talk about what the circadian rhythm is.
So those are periods during the day when you're more apt to be alert versus less apt to be alert. And, when we talk about how you go to sleep, there's a process S and process C. So process S is very simple. The longer you're awake, the sleepier you get. And then ideally, around 10 o'clock, 9 o'clock, 10 o'clock at night, as your sleep depth's very high, your process S is very high, you have that dip in your circadian alertness, and they match up and you fall asleep easily. But it's not always that simple for people.
Okay.
For sure.
All right. So let's talk about the more common sleep problems. Let's start with insomnia. What causes insomnia and, and keeps us, we have trouble falling asleep and staying asleep?
Yep. So at a baseline level, everyone has some predisposition to insomnia that's different, between individuals, okay? And typically what happens in an insomnia, someone who develops insomnia, and we all get insomnia to some degree, everyone has a poor night of sleep, but typically there's some sort of stressful situation or, something happens socially at work, and, that stress kind of perpetuates insomnia and moves you above that like sleep insomnia threshold. And you'll have a few nights of bad sleep. What tends to happen in people who get it more chronically is once they start developing insomnia, they develop really bad habits that perpetuate it. So, you might start staying on your phone longer at night and keeping yourself up. You might start staring at your alarm clock and getting anxiety related to sleep. Just various different factors, playing on the computer, staying up later, where you're passing your ideal time in your circadian rhythm to actually fall asleep. So that's in general what happens is someone's predisposed to, difficulty with initiating sleep. They have some life event that, kind of really starts impacting their sleep. Yeah. And if they don't maintain good sleep hygiene, things will start to perpetuate and it becomes a chronic process.
So how do you treat insomnia?
Cognitive behavioral therapy is really the cornerstone. That's working with a psychologist, ideally, who's trained in CBTI for insomnia. And
What's CBTI?
Cognitive behavioral therapy.
Okay.
Yeah,
okay.
I'm sorry. Yeah.
No, that's okay.
And they do a very thorough sleep history, and really from the time like you get home to start preparing for bed, they go through your routine. They talk about what's happening at night. They sort of rewrite cognitive pathways, give you different behaviors to sort of optimize your sleep and your sleep environment. Long term, that's been found to be the most effective treatment for insomnia. Sometimes we will use medications. They work pretty well acutely, but over time they tend to stop working. And some of the medications we use, you can develop some dependence and things.
Right.
So we do try and avoid some of those medications if we can.
Okay.
Yeah.
All right. What about snoring?
Yeah. So snoring.
Bet you get that one a lot.
Yes. Yes. So snoring can happen for a number of reasons. I mean, a lot of times it's, an anatomic variation in the upper airway. Sometimes very severe, like nasal allergies, things like that. Inflammation in the upper airway can do it. People who develop obesity and, particularly bigger necks, the neck can fall in and sort of cause some airway obstruction. Snoring is different from sleep apnea. About 30% of people snore, but not that many people have sleep apnea.
We're going to talk about that next.
Yeah. And then, alcohol, some medications that can affect airway tone, may lead to snoring as well.
So if you're a snorer, is there anything you can do to stop snoring?
Right. So one of our otolaryngologists actually sees a lot of our patients with snoring. Things to consider. I mean, weight loss helps snoring and sleep apnea. The breathe right strips, for some people will work. They're not very effective for sleep apnea, but can be helpful for snoring. Sometimes if you have a lot of nasal congestion, over-the-counter nasal sprays can help.
Okay.
If they're very severe, one of our surgeons may do like a turbinate reduction to just help with that airway swelling and improve nasal airflow.
Okay. Yeah. All right. Well, we mentioned sleep apnea. So what exactly is sleep apnea?
So obstructive sleep apnea is where your airway sort of collapses while you're asleep. It has consequences where you have big swings in thoracic pressure. It puts a lot of stress across your thoracic organs. You get oxygen desaturation, so your oxygen levels drop pretty precipitously, and then heightened in sympathetic tone.
You actually stop breathing for a while, don't you?
You do, at least 10 seconds to have an apnea. But we do see at times people going 30 seconds up to a minute.
That can't be good for you.
And you think about doing that throughout the night. I mean, people come in with an apnea-hypopnea index, which reflects how many times that happens an hour of 100. So doing that 100 times in an hour, your whole night is sleep. You can understand how that can have really devastating health consequences.
Yeah. So how do you diagnose sleep apnea, and then how do you treat it?
So the diagnosis of obstructive sleep apnea is usually based on a sleep test. So we will do a test in our laboratory, or they do have portable sleep testing available now that people can do in their homes. And we've moved, and that's been nice to try and get access for people to, get a diagnosis of obstructive sleep apnea. So typically what we do is we monitor in the lab, we'll monitor sleep, we'll monitor all the respiratory parameters, looking at airflow, looking at oxygen levels, looking at an EKG. We even stage sleep with an EEG. On the home sleep test, it's more of a respiratory test. We really monitor respiratory parameters, looking at those things, looking at those sensations and airflow, looking at desaturations, looking at heart rate. We make the diagnosis that way.
So once it's diagnosed, how do you treat it?
So there are a number of treatment options. The kind of gold standard treatment for since early 1980s has been a CPAP therapy. That's one of the masks at night that.
And those have changed.
Those have changed dramatically.
Yeah.
I mean, I remember when I started, most people had the big fireman mask, but now, the masks have improved a lot. The machines are very portable and have gotten a lot smaller, and many people can get away with a nasal CPAP, which just almost looks like oxygen in your nose. So much more comfortable, much easier to wear. But despite, the advancements we've made, CPAP isn't for everybody. So we do have other treatment options. We have an Inspire program, which is hypoglossal nerve stimulation. So that looks like a pacemaker that goes right here, but it actually attaches to the hypoglossal nerve and causes the airway to dilate at night and protects from obstructive sleep apnea.
And that requires surgery, right?
That's a surgical implant.
Okay.
And we have 3 surgeons, I believe now, who are doing those implants.
And is there a lot of success with the Inspire option?
There has been a lot of success, and we brought a really good team together. Most of we work closely with the surgeons, and we've started an Inspire clinic at our sleep evaluation center. One of our previous fellows is actually running it now, and he's doing a phenomenal job. And
that's great.
Helping with patients getting accustomed to it and teaching and.
Is everybody a good candidate for Inspire?
No. So, there are requirements you have to meet. One is a BMI requirement. So they did change it. I believe the BMI requirement now is 34. So you have to be under a BMI of 34.
Okay.
And then if you meet those requirements, there are also some things we look at on this sleep study to determine if someone's a good candidate. And then you have to go what's known as a drug-induced sleep endoscopy. So they look at, you get taken to the OR and they give you a cocktail to kind of mimic sleep. And then they'll look down in your airway with a scope to see how your airway collapses.
Oh, wow.
So if it collapses in the AP direction, you're a good candidate. But if you see the lateral walls of the airway start falling in, you're not a good candidate for the procedure.
All right, good to know.
Yep.
Now, I understand you started a rural health mentoring program to teach primary care physicians in West Virginia how to treat, how to address sleep apnea with their patients. Tell me about that.
Yeah, we, my research program has really looked at how do we improve the health of West Virginians. I'm really interested in rural health and ways we can improve the health of Appalachia. And, when we were developing this program, we were thinking, well, maybe we'll start with COPD or something like that. And we didn't have a lot of success. And, we went back to the drawing board and we're thinking, a lot of times we intervene on patients when the disease is already established and there's consequences, and it's really kind of hard to bend the needle once that's happened. So we were like I mentioned, diet, exercise, sleep. So we were like, well, maybe we can do something in the sleep space that would really have broad impacts on different health conditions.
Sure.
So we started out looking at how we're doing at diagnosing obstructive sleep apnea in West Virginia, and based on sort of national metrics and the obesity epidemic in West Virginia, you'd expect 1 in 4 people to have sleep apnea. And when we did an analysis of our Medicaid database, it was about 8% were diagnosed. And when you looked at smaller communities, it was about 2%. So people just didn't have access.
Big deficit,
So, we started this program where we train primary care providers to identify and manage obstructive sleep apnea. And then we developed a database that provides sort of an asynchronous consult. So if they have questions about a sleep study result or, how to manage a CPAP machine, and one of our experts is available to help them navigate that situation.
That's great. Is it helping? Or are you seeing
so
any results?
We've had two training sessions thus far, and we're starting to get some consults come in, which is really great. And everyone, I think we've trained 15 providers thus far, and everyone seems very excited about the program, and the initial results are, very promising. Our next program is scheduled for January 30th. So I hope after this year, we really can start assessing the outcomes and how these patients are doing, and, just what the experience of these providers have been. But I would say our initial response has been very, very positive.
That's great. That's great. Good to hear. And I remember I did an interview with one of the sleep doctors about it. They do testing. I know at Ruby. I don't know if this is a system-wide thing, but where they actually test heart patients that are hospitalized for sleep apnea while they're in the hospital. Is that just a local thing, or is that a system thing?
It's just a local thing, but it is our program's really gotten a lot of national attention for the hospital-based sleep medicine program, because there's just more and more data coming out that shows that if you can intervene on someone's sleep apnea, you can keep them out of the hospital, which is very important. Unfortunately, the field has just been an outpatient field, really since its inception. And I've worked closely with Dr. Sharma, who I think you
That's
referenced.
Who I interviewed.
And we've really sort of started to broaden out the program. We're starting to look at stroke patients now, which is another very important population. And I think we've screened over 3,000 patients now through our program. And not only is that screening important, but it's really helping on the outpatient side facilitate testing and treatment that I think really makes that program a success.
Excellent. That's great. All right, let's get in a couple more sleep problems here.
Okay.
What about restless leg syndrome? What is that?
Yeah, so that's it's a kind of neurologic sleep problem where you get just a sensation, a kind of creepy, crawly sensation, not typically pain, and this, feeling that you can't stop moving your legs, and if you do, you get really uncomfortable. So a lot of people get up, walk. Sometimes massage can help. It's probably driven by abnormalities in dopamine transmission in the peripheral nervous system, associated with low kind of iron stores in the body. And recent data has shown that correcting the iron stores is very efficient. We used to have a fairly low value of serum ferritin, which was a reflection of your iron stores that we would target to treat restless leg syndrome. But now the response people have is so good that we actually target a little higher levels with iron supplementation. And some people are so bad, we'll even bring them in for IV iron infusions because they can really respond. In people who have relatively normal iron stores but still have restless leg syndrome, there are medications we can use as well to help mitigate the situation. And there is a broad presentation. Some people are just are bothered severely by restless leg syndrome, can't sleep, has a huge impact on their life, while others, may have symptoms a couple times a month or something like that. It's
so it can vary
pretty significantly.
Wow. Okay, and what about narcolepsy? What causes that, and how's that treated?
Yeah, narcolepsy is a very interesting disease.
Is it that common?
It's not. It's about one in a million people.
Okay.
Yeah, but we do.
And tell us what it is.
So it's really a disease where you lose your ability to regulate sleep. There's a deficiency in a chemical called orexin or hypocretin in the anterior hypothalamus that, for whatever reason, these really specialized cells that make that neuropeptide are destroyed, and so patients have just severe sleepiness, sleep attacks. They can have hallucinations, which is really like REM sleep, entering into REM sleep even while they're awake. They can have cataplexy, where, when you're in REM sleep, your body's paralyzed. And so that can happen to them while they are, lucid and awake. And it's usually brought on by laughter or any sort of stress. Someone gets scared. Those are common triggers. Unfortunately, there's no cure for narcolepsy. A lot of it is, stimulants. We do have some newer medicines we use to actually help optimize sleep at night so the patients feel better during the day.
Okay.
But a lot of it is just symptom management, unfortunately, at this point. So.
Wow. Okay. Well, it's good that that's not too common, but still got to be dealt with. So let's talk a little bit about the expertise of the WVU Medicine sleep medicine team. I mean, because you got a deep bench here, don't you?
We sure do. Yeah.
Tell us about that.
Yeah, we do have a multidisciplinary faculty, which is phenomenal. And when I started our fellowship here, I think we're on year 5 now. I mean, that's one of the real strengths of the program. We have people in neurology, people in pediatrics, otolaryngology, who are really focused on sleep. And then obviously in our pulmonary division and internal medicine, we have a lot of expertise. One of our previous fellows, Dr. Rojas, is the one who started the Inspire Clinic. Dr. Sharma and I really started the hospital sleep medicine program. And then he's started a phrenic nerve stimulator, the Remedy, which is for central sleep apnea.
Which is different.
Which is different than obstructive sleep apnea. So we really have a lot of the state-of-the-art treatments for disease processes. We work closely with psychologists for cognitive behavioral therapy, as we mentioned, with insomnia. She does a phenomenal job, Dr. Fisk. And then our pediatrics sleep physicians are very good, very good.
Okay.
Yeah.
So before we go, I just want to ask you, what's the most important thing that you want our viewers or listeners to know about sleep problems?
Yeah. So again, sleep is essential for health. And if you feel like you're not getting adequate sleep, or you feel you're still not feeling rested when you get up in the morning, it's something you should bring up with your doctor. And unfortunately, primary care is very busy. People have a lot of things they want to talk about, and it's easy to kind of gloss over the sleep problems, because over time people just kind of adapt to it and say, this is just kind of how I do it, how I sleep. But it's very important to bring up, because you could uncover something that's going to have long lasting health benefits down the road if you have a sleep disorder that can be treated, or there's just things we can do to optimize your sleep.
Okay, and do we necessarily need a referral to, see an otolaryngologist or a sleep team specialist?
It depends on the primary care, what their comfort level is. There's been some interesting work looking at, family medicine physicians, internal medicine physicians. They're not as comfortable managing sleep disorders, at least what the data shows, but they're very good and comfortable at talking about sleep hygiene and ways to optimize health that way, and address things you can do to optimize your sleep.
All right.
Yeah.
Well, thank you so much for sharing this information with us.
Oh, sure.
I'm hoping we're all going to get a better night's sleep after this. Thank you so much.
You're welcome. Thanks for having me.
That brings us to the end of this edition of Live Healthy West Virginia. If you're looking for more information on sleep problems, visit wvumedicine.org/sleep. And to find the latest episode and all episodes of Live Healthy West Virginia, visit wvmetronews.com/podcast, or on the all-new West Virginia Metro News TV app. I'm Mary Ravazio Menard, and on behalf of Dr. Stansbury and everyone at WVU Medicine, thanks for joining us.